So, Revlimid only actually got FDA kind of label as being maintenance only in the last couple of years. And many of the initial trials kind of just said, let's do it for a couple of years. And the Europeans did it for a couple of years. And it was really only that when the FDA approved it based on some of the long-standing trials we had, that we finally start to see an overall survival benefit, meaning that people are living longer by staying on Revlimid maintenance. So that is, right, the holy grail. There's an ongoing trial that the French started that we're finishing up that has basically two arms of it, where the French basically did 2 years of maintenance after a transplant, and the Americans are doing it as long as it's lasting, as long as it's working. That's gonna read out in a while, but that'll be at least an answer to your question about whether, well, I should say, it'll show us that we're right and they're wrong, that staying on therapy as long as it's working is probably the right thing to do. And the secondary malignancy question comes up quite often, and my answer is usually this: you deal with the devil you know. Right? I mean, we are concerned about probably a single-digit % possibility or risk of getting a second kind of a cancer based on taking treatment for your first kind of cancer, which is just someone's bad sense of humor. But I think realistically is if we know that Revlimid, for example, as a maintenance strategy is saving lives, I think it's worth that personally, and this is for each of you to make your own individual assessment, but I think it's worth the small risk of getting a separate form of a cancer.
I think I would just add that the initial studies that were done with Revlimid that Dr. Costello alluded to, there always seems to be a pairing of a US and European study. So it was actually in the same New England paper. The American study was Revlimid till progression. The French was 2 years. And in that study, both showed that the remission duration is 2 years without Revlimid maintenance, and it went to 4 years with Revlimid maintenance. Interestingly, in that study, the American study showed survival benefit, but the French did not. So you might immediately say, well, so we should be using Revlimid till progression. The problem is, though, that overall survival is not just the risk and benefit of what you're doing, but also what happens after that's done. So what I'm referring to is that when people progressed on Revlimid maintenance in the US, we typically in that time would have gone on to Velcade-based therapies. In France, they got a lot more Revlimid, thalidomide, which are inferior salvage regimens. So this shows that even though you might have a benefit, you might lose the benefit if you don't treat them appropriately after they progress. So I think the jury is out. A lot of the European studies tend to limit the duration of Revlimid, not necessarily because of medical issues, but more fiscal issues, right? There's a lot of cost containment that's happening across the world, and so that's the primary reason outside of US it's controlled. But the last point is the numbers in terms of secondary cancers, it's a doubling. It is a significant increase. So in the control arm, it's 3 to 4%. And that's important to spend a second on too, because part of the reason myeloma patients get other cancers is because of the genetic complexity of myeloma, right? So the Swedish have already shown that even MGUS and smoldering myeloma patients have a higher risk of secondary cancers than age-matched controls. Probably because whatever genetic instability led to getting MGUS or smoldering can also increase the risk of other cancers. And then when we come in and do transplant, which also is a big, the chemotherapy melphalan does definitely create more DNA damage. And then we also follow up with Revlimid. It is a 1, 2, 3 punch. So as a result, Revlimid alone, no maintenance after transplant has a 3 to 4% risk of secondary cancer, and that goes to 6 to 8% with Revlimid maintenance. So it is a doubling. But remember, as Dr. Costello pointed out too, if people are living longer, it means they're not dying of these other cancers, right? There's no way, if there were so many extra cancers from Revlimid, that you would see people living longer from a myeloma perspective or any perspective, right? And so I think the important message is if you are getting Revlimid maintenance, do age-appropriate healthcare screening, mammograms, skin exams, colonoscopies, whatever you're supposed to be doing, keep doing that, getting your blood counts checked, but don't throw the baby out with the bathwater is my take on it.
No. What I was just going to say that, and then obviously we're talking about maintenance post-transplant, but then when you look at, the non-transplant population, right? When you looked at an initial the first trial which showed us that Revlimid Dex was a good treatment. Now, of course, that's outdated. But the interesting part about that treatment is they had two arms of Revlimid Dex. One was continuous Revlimid Dex, and the other one just gave Revlimid Dex for a fixed duration. I think it was 18 months, and then they stopped. And it was only the patients that continued on therapy that actually benefited. They actually did much better. They stayed in remission longer, and they lived longer. So that kind of is what led to the idea of continuous therapy. So that's a different scenario because that was full doses of treatment. But I think it's also you can kind of think about it in the maintenance setting. That's the same idea, is that for some reason that continuation, that continuous suppression is still important. So the question was, CAR Ts work, but not for that long, so why do it? No, I'm just kidding. I paraphrased. No, I think it's a fair question. And I think it's interesting. So again, you have to kind of keep in mind the population we're talking about, right? So Dr. Chari just gave you a half-hour dissertation on why selinexor is so potent when we're talking about really patients who have failed everything and getting response rates of 30% and staying in remission for about 3 months or so. Well, if you look at sort of Darzalex and you look at all these Pomalysts when they got approved, that's sort of how long patients stay in remission is about that 3 to 4 month range. So when we're looking at CAR Ts, you're seeing response rates of 80 to even 100%. And very high rates of complete remissions. And at least the one study that has shown us sort of the progression-free survival, we're talking about a year. So that's still a quadrupling of what you normally would see with some of these other drugs in that patient population. So it's disappointing because I think it is a very sort of kind of cumbersome therapy and treatment that requires a lot of logistics and potentially toxicities that can go on for quite a while, mostly from the standpoint of recovering blood counts, that we were disappointed with those numbers and we were hoping that this was finally our cure. But again, you have to put it in perspective of which population we're talking about. So the question will become, every drug, as you move it earlier, becomes better. So the question will become whether this will eventually translate to much more durable remissions. As to why patients are progressing, that is an excellent question. We don't know the answer to that. There's a lot of studies going on in terms of what is happening. If you go to the literature with CAR Ts and lymphoma, most of those CAR Ts are targeting this protein called CD19. A lot of those patients who are progressing are actually CD19 negative, so they're basically losing the target, and so that's one theory. But when you actually look in myeloma, that doesn't seem to be the case. The majority of our patients who are progressing are still BCMA positive. And so it seems to be a very different mechanism. Again, it probably goes back to what Fotis was telling us, because I can't say his last name. In terms of sort of kind of the myeloma recruiting all these different things in the microenvironment or making that somehow are even affecting these CAR Ts. So the CAR Ts they're not always necessarily going away. Sometimes they're staying, but they're no longer functional. And so there's some inhibitory processing that is going on. But that is all an active area of investigation.
So you just witnessed the first disagreement. He said, I cannot remember your name, and I was thinking, you got to remember my name, so we'll continue this at the back. So I think that to my mind, and Jesus is the world expert in CAR Ts, but he's very right that part of the problem in some patients is that you lose that that the myeloma cells lose that BCMA target. So the question that arises is when we have different targets, because inevitably we will, and research is very active in this regard, we're looking for targets that clearly are specific to myeloma cells as much as possible and are not relevant for normal cells. Will we see the equivalent of those BCMA negative relapses? The other thing I would say is that if you have a criminal who's loose, you have to do two things. First of all, you have to lock them up. That's MRD. And the second thing is you have to have a good guard. Someone has to guard the door. And that is the immune system, or what we call immunological memory. So for eventually, for long-standing remissions, and if we don't get to eradicating every single criminal, which we know in most societies is not possible, this is the way we're going to be thinking, right? So we need MRD and immunological memory. And we are getting better and better at figuring out how we can convert the CAR T response or CAR Ts into being memory cells, into having what we call immunological memory. Because immunological memory is the gift that keeps giving, right? I mean, you went through, mumps or whatever when you were a kid, and then you don't get it again because you developed immunity. I mean, that's the whole point of the immune system, and immunological memory is the golden property of the immune system that, keeps life going. So at the level of myeloma, you would want to, and that's a lot of the research is actually looking at, okay, we take those T cells from the patient, and what's exactly in that population? Do we have cells that are likely to give us this immunological memory, or how can we boost that? So I think we need to get better at both the target issue with more targets, and they're coming in the pipeline. And the second thing would be how to enhance the ability of CAR Ts to provide this long-standing protection.
Well, since you had your dissertation, no, I'm just kidding. Two quick points I wanted to make. I think the problem with CAR T, one is that remembering that these are really being done on right now transplant-eligible patients. So these are not sick, fragile, elderly patients. That cytokine release syndrome is manageable in young, fit patients, but in an older patient, low blood pressure could result in a stroke or heart attack. So we need to expand. I think this is a big problem in myeloma in general. We're dealing with a median age of 65 to 70, but clinical trial median ages can be as low as high 50s and low 60s. So it's not representative of the entire population. And then the second big problem is the time to develop the drug. So you're talking about patients who've been through 7 prior therapies, rapidly explosive disease. There's a tremendous cherry picking of patients up till now because of the limited CAR T slots. And so I think as the manufacturing period shrinks, we might see these numbers even getting worse, right? Because the sicker patients are going to be able to get on. And we already know, even in spite of that, lymphoma patients, about 10 to 20% of patients who actually start the collection process don't get to the actual CAR T infusion because the disease is so explosive, right? So some of the things that I think are exciting are off-the-shelf CAR Ts. There's some very interesting data that came out where they have cells ready to go. It doesn't require any manufacturing, allo NK cells that we're showing dramatic activity in multiple hematologic malignancies with no cytokine release syndrome, right? So that, I think, is really exciting because that could be applied to even older patients. It's ready to go. You won't have to wait 4 to 6 weeks. So that's some of the innovation happening out there that I think really excites us. And definitely CAR T is amazing. It's a one-time intervention, but right now it's not for every patient.
He was on Revlimid and Velcade and Dex, and the Velcade was dropped because of concerns for liver inflammation and replaced it with Daratumumab. Can we still use an M-spike to evaluate the response to therapy? Absolutely. So you're right, there are a lot of patients who had tandem transplants and may be so lucky to have extra stem cells hidden in the freezer for a rainy day. And I think broadly, when we think about these days nowadays is when is a second transplant worthwhile? Well, you want to look at the success, quote unquote, of the first transplant in the sense of how long did it last for? Because there is some thought that a second transplant after the fact will probably not last as long as the first one. So when you're weighing out your risks and your benefits of undergoing a second transplant, you want to understand how long do you expect it to work. So for someone who had a transplant and 5 years later, relapsed, and we're talking about a second transplant, it's probably worth it. I mean, that first set go around was pretty durable. And realistically, if you got another 2-3 years out of a second transplant, I think it's a realistic option, worth the conversation depending on your goals of care at the time, what other treatments are available. You will have used up some more treatments in order to get the numbers back down again prior to that second transplant. I think we've all probably had patients who've undergone 3 transplants before, and sometimes it just is an option in the toolkit. If you really don't necessarily have other options, maybe that's worthwhile. I think that the further along in the disease course you get, the less helpful eventually the transplants are going to be. And so if they worked well for you from the get-go, it may be worth the world to think about it for your third, even though technically it's maybe your second, in the grand scheme of things, because that tandem transplant was kind of a one-line treatment. I don't know. Want to add to that?
I just wanted to clarify, I think when we think about second transplants, they come in 2 flavors. One is first transplant followed by an intended second transplant immediately. That's a tandem. Whereas a first transplant, long gap, second transplant. The reason the first type of transplants are diminishing in frequency is tandem transplants started when we had very few drugs, right? So back 20 years ago, if you just had, cyclophosphamide, Dex, Melphalan, many patients you would do, or thalidomide, you might get a significant drop with your first transplant, but there's still quite a bit of disease, and then you would do the second one to mop it up. Now, with such effective induction therapies, people are entering the first transplant with very little disease, and if one transplant doesn't take care of it, it's unlikely that a planned second immediate transplant is going to do very much. So that's why you're seeing very little tandem transplants in the current era, and that's one of the benefits of doing deeper induction therapy, because then you don't have to go through that whole thing again, right? Now, the delayed transplants, a second transplant, that one historically, as Dr. Costello said, whatever remission you get from your first auto, the second one tends to give you at most 50 to 70%. So you can divide people into 2 categories. If you had an amazing first auto remission, 6 years, definitely consider that second one. But if your first auto was barely a year and a half, what's the point of doing that again? And in that setting, we tend to save that second transplant when we can't do anything else. So let's say somebody's blood counts are too low, they're not eligible for clinical trials. This second transplant can transiently clear out the myeloma, get those blood counts up. It's not going to last long, but then the minute the myeloma numbers go up, this patient will be ready for a clinical trial, such as a CAR-T or a bispecific. Generally, we recommend collecting cells within 4 to 6 cycles of Revlimid to avoid impairment of the collection. For that reason also, we try to avoid radiation in newly diagnosed patients, if at all possible, to minimize stem cell collection issue. I think that you're a testament to, above all, do no harm, right? Because if somebody had treated you 8 years ago, they would have been taking credit for your excellent health, and has nothing to do with our treatments, right? So, so the natural history of myeloma numbers tends to be a constant slow increase. It's rare in smoldering and MGUS to see a downward trend. One of the possible explanations might be if somebody gets steroids for some reason, for some other condition like COPD or other things. If that's not it, supplements we've had some patients kind of have interesting results from astaxanthin, curcumin, resveratrol, all of those things that we were talking about earlier have shown some data, but generally that's not common. And I think I always tell people, I love when you're medically boring. I like my job to be kind of straightforward, and so if you're boring year after year, that's great, and it looks like you may be in more of an MGUS phase. So statistically, as you saw on that curve, after 5 years, there's kind of an inflection point, and the rate of progression really diminishes, and now, after 8 years, it's even less. It's not 0, but very close.
Yeah, no, we have no idea what's the prayer. I don't know, but there is also, I guess, a question of whether was it just one light chain that was up and the ratio was really high, or were they both really high? Because there are some inflammatory conditions that can send all the antibodies and the light chains up really high, and then they kind of plateau a little bit down. So that could have been a possibility. So I mean, I think that's back to the story. When we talk about smoldering myeloma at diagnosis, we're all trying to predict who are the patients that will be like you that may never require therapy. And I think, if you look at sort of the long-term data, we're talking about maybe about 20% of patients that may never move to active myeloma. So hopefully that's you. And as you get beyond those 5 years, you revert back to that MGUS state where you're looking at 1% per year, perhaps. And that you're probably the perfect person to quote those numbers. But when we're talking about smoldering myeloma at the very beginning, we're talking about who's high risk to develop active myeloma, and we're talking about a group of patients that has a 50% chance of becoming active in 2 years. And so that's the difference. So in terms of, how do we define that? And there's a lot of controversy right now in terms of who that group of patients is that may benefit from treatment versus a patient where we don't want to do any harm. But I think you've definitely passed the test. So regardless of what your characteristics were at the beginning, clearly you're not in a high-risk group.
I just thought that from the molecular point of view, cases like yours are actually fascinating and make more sense because we know from solid tumors, going back to this branching structure of these tumors, it turns out, as Dr. Chari mentioned, that what you expect, and that's the natural history of most cancers, is that a mutation will set the stage for another mutation that will make the cancer cell more aggressive, right? That's how kind of cancer cells progress and grow, and sometimes they grow quite, in quite a fast way. Turns out that recent studies in solid tumors taught us that actually some of the mutations create hard stops. That basically you have this branching, and by chance, a mutation happens that actually, almost paradoxically, in combination with what else we find molecularly in that branch, that creates a hard stop. And we haven't, to my knowledge, we haven't seen anything this or documented anything like this in myeloma, but if it happens in solid tumors, I would not be surprised. And you remember that graph I showed, you have the big players, the RAS mutations, but that cloud was full of less common mutations. And it is quite possible that actually you will have a mutation A, mutation B, but mutation C actually makes A and B to be inactive rather than be an additional drive for that branch to grow even further. So I think that this is fascinating, and obviously it happens in real life, and I think we understand molecularly more and more why that might be the case.
You need his bone marrow.
Totally. Come to my office after. I have an espresso machine as well. I'll give you after the bar. Let's not get into this.
We should differentiate between clinical relapse, which is the development of crab features again, where you have hypercalcemia or kidney problems or new worsened anemia or new bones or new bone problems or new plasmacytomas. Clinical relapse, which we are all desperately trying to avoid. We don't want new damage done. So instead, we hope to watch for biochemical progression. Biochemical progression, we watch that M spike or your light chain, whatever your disease manifestation is on your blood test. And it's important when patients are growing, there are different rates of growth. We all want to catch the person whose M spike is rapidly rising, because those are the people who are going to have clinical relapse. They're going to have new bone, irreversible body damage. There are people for whom which M spikes are going to start trickling upwards. You need to understand what that rate of growth is. There are some people we can sit on our hands and watch those numbers very slowly change. By absolute difference, if the M spike grows by 0.5, progressive disease, by clinical response criteria. We know that 0.5 change is progressive disease, and that would prompt the initiation of therapy for us. If patients, even if they still haven't made that 0.5 change, but it happened overnight, I think many of us would want to intervene pretty quickly. If it goes from 1.0 to 1.1 to 1.2 over the course of 6 months, you're going to feel a little bit more content maybe sitting on your hands and watching. We want to intervene before you've jumped off that cliff. We want to grab you as you're heading towards the cliff, but are still about 50 yards away.
I would just add the points of, we talked a little bit about MRD. So this whole era is, as we detect disease at a lower and lower level, there's going to be these kinds of questions, right? So if I go from MRD negative to positive, do I need to start therapy? And then if I go from IFE negative, which is a way of detecting very microscopic amounts, to positive, do I need to start therapy? And then and so what we know, I think important part, as Dr. Costello is mentioning, is crab symptoms are super important, right? So no one's gonna question, if you have crab symptoms, it doesn't matter. And there's some patients we haven't talked a lot about, but oligosecretory and non-secretory, they don't make any proteins, right? If you have a new plasmacytoma, even if your numbers are 0, you need to start therapy, right? So clinicals always trumps. The disease level is less important. The only exceptions I would say is that, again, rapidly progression, but also high-risk patients. So in high-risk patients, when you see that number first come back up, like in the 17p deletion, and it's rarely early after transplant, you better start getting prepared to start something soon, even if at that moment it's very low. So I think those are some important considerations. But the whole MRD negative, I was at a debate in New York, and the question was, I was assigned we should treat MRD negative to positive conversions, but we'll leave that for now.
So, but I think that is a really important question, and I completely agree with what they both said. The only other thing I would add is I think it also depends on the person, right? So again, going back to the type of disease they've had, the type of treatments, how long have you stayed in remission, and how quickly you're progressing are important, but also the toxicity. So if the person had a really hard time with treatment and they're still trying to get over a lot of those, and you're just starting to see an uptick, that's somebody where you might not want to pounce really quickly on something else if you can help it to buy some time. So I think you have to individualize it in general. But I think, the Spanish looked at this in terms of patients who actually met the criteria for chemical progression, in terms of how long did it take for them to eventually to have clinical progression. And it was actually not that long. It was actually 6 months or less for most people. So I think, it kind of goes back to the idea of how long do you wait before you pounce, and it's going to be a discussion between your doctor. You may be the kind of person that if you're already upticking, you're like, I don't feel comfortable, I need to get back on treatment. Or you might be the person who's like, oh, no, I hate these drugs, I'm gonna wait a little bit, and maybe I'm gonna wait till I have some new symptoms.
One other thing I would say is one data point does not make a trend. And because we can see some fluctuations in your M spike or whatever, check it again. And do it in short term. If you're ticking up and you have high risk disease, check it again within the next short period of time so you can make sure it wasn't just a one-off.